So, as we mentioned, our session today is approach and management of a case of suspected PE in pregnancy according to recent NICE guidelines. I'm Dr. Rock, consultant acute medicine, endocrinology and diabetes in Eastbourne General Hospital, MRCP, SSC acute medicine, SSC endocrinology and diabetes, European Board of Endocrinology and Diabetes. Um, so let's start first. How is acute VTE diagnosed in pregnancy? Or especially PE? We are talking about PE. Actually, as you know, the symptoms of PE um, varies from one patient to the other, and it can come with a symptomatic patient, even to shocked patients. So patient with suspected PE can come with mild chest tightness or discomfort, mild dizziness, or even tachycardia, just mild tachycardia. And up to shocked patient, the patient may present with hypotension, tachycardia, and cardiovascular vascular decompensation. So I want to start from the beginning. So as you see, the patient with PE may varies from atypical in most of the cases and varies from asymptomatic patient to even shocked patient. And all physicians should give a low threshold for a diagnosis of PE because PE is serious condition and life-threatening, especially in a case of pregnancy. And any woman with symptoms or signs suggestive of PE should have objective testing performed and treatment of low molecular weight heparin given at once until PE is excluded. Um, and of course, every hospital has its own protocol, but I think all the hospitals have the same protocol of management of PE according to NICE guidelines. So the conclusion from this slide is that PE is a serious condition and we should give a very low threshold for a diagnosed PE. Um, and we have to bear in our mind that PE may vary from a symptomatic patient with mild symptoms or even without symptoms up to shocked patient. What are the investigation for suspected PE in pregnancy? So now you are suspecting PE, what you are going to do? Are you going to do D-dimer? Actually, D-dimer has no rule in PE in pregnancy because D-dimer will be high anyway in pregnancy. So there is no rule of D-dimer in pregnancy. What if someone did D-dimer and came back as normal or low? Does it rule out PE in pregnancy? May I ask you kindly? If you did D-dimer and came back as normal or low, does it rule out PE in pregnancy? Just to be interactive with each other.
No.
Yeah, it doesn't rule out PE in pregnancy. You still have to go to and proceed for further investigation, either CTPA or VQ scan, because pregnancy itself is high risk of venous thromboembolism. Pregnancy itself can cause hypercoagulable status, which can predispose the pregnant lady for any VTE, either DVT or PE. So let's agree, D-dimer has no rule at all in pregnancy, and you shouldn't ask for it. ECG and the cardiac enzymes is very important in any case of chest pain to rule out ACS, as ACS can happen as well in pregnancy. So we still need to rule out ACS as a serious condition. Chest X-ray. Chest X-ray is very important in any case with suspected PE in pregnancy, actually, because chest X-ray can detect any other lung pathology like pneumonia, pneumothorax, lobar collapse, atelectasis, which can explain the chest pain. Chest pain is important as well because according to chest X-ray finding, you are going to decide this patient will go to CTPA or VQ scan. For example, if the patient has abnormal chest X-ray, no rule for VQ scan at that time because there will be mismatch and you have to go to CTPA. VQ scan is done only in normal chest X-ray patient without history of pulmonary or any long-standing lung disease at all. Okay, some physician may be worried, or even the patient themselves may be worried about exposure of radiation for chest X-ray. We have to reassure them that the radiation dose to the fetus from the chest X-ray at any stage of pregnancy is negligible, and it is even less than 0.01 MSD. So it's very negligible, actually, dose of radiation to the baby, and less likely to has any impact on the baby. As we mentioned, chest X-ray should be performed before deciding the next further scan of choice, either VQ scan or VT or CTPA. Because if chest X-ray is abnormal, there is no rule for VQ scan at that time. Arterial blood gas, ABG. ABG has limited diagnostic value in diagnosed PE. I mean, it doesn't confirm or doesn't rule out PE, but it can support a diagnosis of PE in a case if there is respiratory alkalosis. But even respiratory alkalosis can happen in other conditions, like pregnancy itself. It can cause respiratory alkalosis, and it can happen in PE. It can happen even in pneumonia. All right. So the presence of hypoxia in ABG and normal chest X-ray raise the suspicion of PE and make the likelihood of PE is in a high percentage at that time, because there is no other explanation, alternative explanation of the hypoxia. So this is one of the important points of ABG as well. Doppler ultrasound. What is the role of Doppler ultrasound in a case of suspected PE? Only do Doppler ultrasound if you have unilateral leg swelling. So the guideline is saying if you have unilateral leg swelling and suspected PE, do ultrasound Doppler. If the ultrasound Doppler is positive, treat as PE and start anticoagulation directly. If ultrasound is negative, but there is low level of clinical suspicion, so anticoagulation should be discontinued at that time, and you might need to proceed for CTP. If ultrasound is negative and the high level of clinical suspicion, you have to continue anticoagulation, and you have to proceed for CTP. What if it's a case of DVT, just you don't have any evidence of PE, all right? So the patient came with unilateral leg swelling. It's a case of suspected DVT. If it's of suspected DVT, no rule for D-dimer, go to ultrasound Doppler directly. If ultrasound Doppler is negative, you have to repeat it after 3 to 7 days. And we have many cases actually here, came with normal or negative ultrasound Doppler in the first instance, and after repeating the ultrasound after 7 days, they came with extensive DVT. So if you are suspecting DVT in a patient, on a pregnant lady, you have to do ultrasound directly, and if it's negative, you have to repeat the ultrasound on day 3 and 7. Actually, we are repeating it only once, and in day 7, according to our local policy here in the trust. CTPA and VQ scan. So which one of them would you prefer to do? Let me to ask you and involve you in our discussion. What would you like to do, CTP or VQ scan for a lady with suspected PE in pregnancy? Any ideas?
Would you go for a VQ scan in preference to CTPA?
Why did you prefer VQ scan?
Just because if you use contrast, then obviously the fetus is going to get the contrast as well. Whereas with VQ scan, it would just be in the lungs.
Yeah, but don't forget that VQ scan can give radiation to the baby as well, isn't it? So both of them, they are giving radiation to the breast of the mother, to the breast of the lady, and to the fetus as well. Any other Ideas? Any other thoughts? Okay. So actually, let's go to the next slide. It can explain to you why, which one of them we have to prefer, VQ-scan or CTBA. This is VQ-scan, CTBA versus VQ-scan in pregnancy. Actually, let's agree that CTBA is a gold standard and it has high sensitivity and specificity for a PE. VQ-scan will give you 3 reports: highly suspected PE, medium or medium suspected PE, or low probability of PE. If it gives you a report of medium probability of PE, you are again in another dilemma because you still need to rule out PE and you need to do further investigation, CTBA maybe again to do CTBA or repeat VQ-scan. So the problem with VQ-scan, it is not as sensitive or specific as CTBA. All right, there's the first one. The second one, if you compare CTBA to VQ-scan, CTBA is giving more radiation, more risk of breast cancer to the lady, but it gives less risk of cancer to the baby. VQ-scan give more risk of breast cancer, more risk of fetus cancer, and low risk of breast cancer. In every case, you have to discuss with the patient about VQ-scan versus CTBA, and she is the one to choose which one is more suitable for her in terms of exposure to radiation and risk of cancer. So the risk of cancer for both breast and baby and on both CTBA and VQ-scan are very, very small. As you see, it is 1 to 280,000 in VQ-scan and 1 to million in CTBA. So still the risk is very low, but you have to be honest and you have to tell the patient that the risk of, if you did the CTBA, the risk of exposure to the risk of to have cancer to your baby will be much more than the VQ-scan. But the risk of breast cancer would be less than VQ-scan. VQ-scan carry higher risk of exposure to fetal cancer than CTB. In most of the cases, of course, most of the moms will prefer to have the risk on themselves rather than to put risk on their babies. And at the end result, as an end result, they would prefer CTBA on a VQ-scan because VQ-scan again carry more risk on their baby than a CTB. So when we can use VQ-scan then? We can use VQ-scan in the case of severe kidney impairment of GFR less than 30, for example. This is one of the indication for VQ-scan. Or it can be used for as a first choice in young women, especially if there's a family history of breast cancer, because exposure to CTBA may increase the risk of breast cancer, or has had a previous CTBA, so that we don't need to increase contrast or increase the risk of radiation for CTBA. So the only use of VQ-scan actually in pregnancy in a case of severe renal impairment, or if the patient has a family history of breast cancer, or the patient just had CTBA recently, or the patient choice. The patient herself, she preferred VQ-scan over CTBA. So I hope that this comparison between CTBA and VQ-scan, I explained the assembly and you got it. Because we have actually this dilemma in A&E or acute medical units all the time about CTBA or VQ-scan. So again, CTBA is the best in terms of specificity and, oh, thanks a lot. Thank you. In terms of specificity and in terms of sensitivity, in terms of exposure, less exposure to radiation to the baby and less risk of fetal cancer. Okay. What is the rule of PRO-test probability assessment? As you know all, in the case of PE normal patient, we are doing Wills score. There is no rule in Wills score in a case of pregnancy. Don't do pre-test probability at all, because pregnancy itself is a high risk factor for PE. So don't do Wills score for patient with PE. Don't ask for D-dimer. If you are suspecting PE, go directly to the urine investigation. And in terms of chest X-ray, ECG, troponin, and CTPE versus VQ scan. Then, of course, the preference are for CTPE. So again, there is no rule for Wills score or D-dimer in PE. It's actually the approach here is a bit different from the approach of PE in other patients. This is just a simple algorithm for approach of a case of suspected PE in pregnancy. So here we are suspecting PE in pregnancy. You have to check, first of all, do you have a leg symptoms? You have unilateral leg swelling? Yes, you have to do Doppler. If Doppler is positive, so treat as PE. If Doppler is negative, go to chest X-ray. Chest X-ray is abnormal, go to CTPE. Here, they mentioned that CTPE is chest X-ray is normal, go to VQ scan, but actually we have a discussion about that, and we had a discussion about CTPE versus VQ scan, and we mentioned at the end as an end result that CTPE is more preferred than VQ scan, and the only VQ scan is prescribed or is requested in patient with severe renal impairment with GFR or creatinine clearance less than 30, or patient with recent exposure to CTPE, or patient with a family history of breast cancer, or the patient choice herself. Of course, if CTPE is positive, treat as PE, and if it is negative, just stop treatment. What if CTPE is negative and you are still highly suspecting PE for the patient? What do you think? What's the next step? The patient still has periodic chest pain, tachycardia, shortness of breath unexplained, and after doing CTPE, which came back as negative. What do you think? What the next step? Do you think we have to just chart the patient home, or search for other diagnosis, or treat as PE, or what do you think? What can we do? Any ideas?
I think look for another cause of the symptoms.
Yeah, but there is no other cause actually. Chest X-ray is normal, no pneumonia, no pulmonary congestion, no atelectasis, and troponin is normal, ECG, sinus tachycardia, no other diagnosis at all. At that time, you can think about repeating CTP again. It is a serious condition, and it can be missed because of artifact or because of inappropriate, imaging. So you have to repeat it again. If you are still highly suspecting PE and CTP came back as negative, you can repeat CTP again. You can put the patient on anticoagulation, and you can repeat it after a couple of days or 3 days. It's the same, it's similar to DVT actually. If you are still suspecting DVT in pregnancy, the first ultrasound is negative, you have to repeat it after 7 days. But here, you have to repeat it after 3 days. Don't leave the patient for 7 days. What the initial treatment for VTE in pregnancy? VTE, of course, we are talking about PE. So what the anticoagulation of choice? What do you think in the case of confirmed PE in pregnancy? Any ideas? Can we use apixaban or dabigatran or rivaroxaban in pregnancy? Of course, oral anticoagulation are totally contraindicated, either DOAC or warfarin. So Oral anticoagulation is not given during pregnancy due to greater risk of bleeding and teratogenic risk of to developing fetus. So the anticoagulation of choice in a case of PE pregnancy is low molecular weight heparin, and the dose should be 1 milligram per kg BD. Unfractionated heparin is reserved for cases of massive PE. And what the definition of massive PE? If the patient came with highly suspected PE or confirmed PE with more than 40% of vasculature involved and with hemodynamic instability. At that time, the treatment of choice will be unfractionated heparin and in combination with thrombolysis in this case. Again, oral anticoagulation is contraindicated in pregnancy. Actually, warfarin started to be given in the second decade and third decade, but this is in the case of other cases, actually, like metallic valve, but not in PE in pregnancy. IVC filter. What's the role of IVC filter in the case of PE in pregnancy? It may be inserted prior to delivery, as anticoagulation will need to be held or stopped at that time because of risk of bleeding. Or even if PE occurred in the antepartum period and delivery should be delayed if possible to allow maximum time for anticoagulation rather than putting in a filter. So the only rule of temporary IVC filter in PE in pregnancy is if the patient is prior to delivery and she has high risk of bleeding, we can insert IVC filter at that time and stop anticoagulation. So the conclusion of this slide, treatment of a choice in a case of VT in pregnancy is Clexane or enoxaparin, 1 milligram per kg BD. We are going to the duration later on for how long we'll be on anticoagulation. What is the maintenance treatment of PE? This is the duration for how long you are going to continue on Clexane for this patient. The recommendation is in a dose, Clexane will be in a dose of 1 milligram per kg BD and for at least 6 weeks postnatally. So you have to continue Clexane at least 6 weeks postnatally, after which you can discontinue it if the risk of VTE is low. What if the patient had PE in the third trimester? We can say in the 39 weeks gestational age. For how long we are going to continue anticoagulation? It should be at least 3 months total. So if the PE happened late in pregnancy, you have to continue anticoagulation for at least 6 months total. Yeah. Of course, outpatient clinic follow-up should be done for clinical assessment and advice with monitoring of platelets, because as you know that Clexane can cause HIT, heparin-induced thrombocytopenia. So you need to monitor the platelets and to monitor the peak of anti-factor 10 level if appropriate. Of course, pregnant women who develop heparin-induced thrombocytopenia or have heparin allergy and require continuing anticoagulation therapy should be managed with alternative anticoagulation under specialist advice. What if the patient develop HIT? What anticoagulation of choice? Fondaparinux. Fondaparinux is the treatment of choice or alternative anticoagulation, safe anticoagulation in the case of if the patient developed HIT anytime, heparin-induced thrombocytopenia. This is advanced, could be advanced point of information for your side, but just to be aware about it. Any patient pregnant with confirmed PE needs monitoring even after delivery. Should anticoagulation therapy be altered during labor and delivery? Now the patient is going to give a baby. What you are going to do? When to stop the anticoagulation? You have to advise the patient to stop anticoagulation at least 24 hours before delivery. 24 hours before delivery. Any regional anesthetic or analgesic techniques shouldn't be undertaken until at least 24 hours after the last dose of therapeutic low molecular weight heparin. and it can be continued again after 12 hours of delivery. What anticoagulant therapy should be employed in women at high risk of hemorrhage? If this lady has history of menorrhagia before, or history of bleeding, vaginal bleeding before, or history of upper GI bleeding, so she's considered to be high risk of hemorrhage. Which anticoagulant of choice at that time? At that time, any patient who is considered to have high risk of hemorrhage should be managed with intravenous unfractionated heparin until the risk factor of hemorrhage have resolved it. Why unfractionated heparin? Because intravenous unfractionated heparin, you can monitor the ABTT for this patient, so that you can monitor the bleeding tendency of the patient. In addition to that, this patient can be easily reversed. Their bleeding could be reversed with antidote, which is protamine sulfate. If the risk of bleeding is prolonged, you cannot leave the patient on unfractionated heparin for a long time. At that time, you have to insert a temporary IVC filter and should be strongly considered. And in all cases, of course, you have to involve hematologist in such conditions. How should anticoagulation be managed postnatally? Anticoagulant therapy should be continued for the duration of the pregnancy and for at least 6 weeks postnatally, or until at least 3 months of treatment has been given in total. Before discontinuing treatment, you have to consider, the risk of thrombosis. If it's still high risk of thrombosis, you might need to consider to continue on anticoagulation. Women should be offered a choice of low molecular heparin or oral anticoagulant postnatally. After discussion about the need of regular blood tests for monitoring of warfarin, particularly during the first 10 days of treatment. Warfarin is safe in lactation. So you have to offer the patient after delivery, would you like to continue on Clexane for another 6 weeks, or oral treatment in the form of warfarin? DOAC is still contraindicated in post-pregnancy and lactation. Warfarin is safe, the only anticoagulant, oral anticoagulant, which is safe during lactation. So you have to give and discuss with the patient about her choices after delivery, if she wants to continue on Clexane or to continue on warfarin, but you have to explain to her that warfarin need close monitoring of INR in the first 10 days. I think most of them are going to be referred Clexane because just 12 weeks are remaining, so they will be in the if they started on warfarin, they put them in hard time actually for close monitoring and daily blood sampling for INR. Postpartum warfarin should be avoided until at least 5th day. So if the lady decided, I want to start warfarin, doctor, I get bored, I pissed off from this Clexane every day, 2 times daily, and I'd like to start warfarin. At that time, you can start warfarin, but after day 5 of delivery because of the risk of postpartum hemorrhage. Women should be advised that neither heparin and unfractionated or low molecular weight heparin nor warfarin are contraindicated in breastfeeding. Again, DOAC is still contraindicated in both pregnancy and lactation. Measure to prevent the development of post-thrombotic syndrome. Post-thrombotic syndrome is long-standing condition after severe DVT, which can lead to valvular dysfunction of the deep venous system and lead to severe swelling and pain, chronic severe swelling and pain after DVT. To prevent this post-thrombotic syndrome, you have to put the patient on graduated elastic compression stocking should be worn on the affected leg to reduce the pain and swelling. Clinicians should be aware that the role of compression stocking in the prevention of post-thrombotic syndrome is unclear, but it can be helpful. Postnatal clinic review, as we discussed before, such patients need to be seen and to be monitored very closely in an obstetric medicine clinic or a joint obstetric hematology clinic. And thrombophilia screening should be performed once anticoagulant therapy has been stopped, and only it considered that the result would influence the women's future management. Thank you all. We finished our session today about approach of PE in pregnancy. Open discussion if you have any question or any worry about our session today. Anyone has any question at all? Okay. May I ask if you get any information from our session today? Okay, as a conclusion, PE in pregnancy, if you are suspecting PE in pregnancy, don't use Wills score. There is no rule for risk stratification, here, and there is no rule for D-dimer. If you are suspecting PE, go directly for to do further investigation for PE. Ask for investigation of chest pain and shortness of breath, including chest X-ray, ECG, and troponin, and CRP, and FPC, chest X-ray, and we agreed that chest X-ray has very minimal risk of exposure of radiation. It is 0.01 MCV, which is negligible radiation dose to the baby. And after chest X-ray, go directly for either CTPA or VQ scan. And we agreed that the preference is still for CTPA in terms of specificity and sensitivity in terms of safety of the on the fetus, because it gives just low dose of radiation to the baby in comparison to VQ scan. And if PE is confirmed, started treatments with Clexane therapeutic dose for the whole time, the whole duration of pregnancy until 12 weeks after delivery, or if the PE is confirmed in the late pregnancy, total 3 months. If CTPA came back as negative and you are still highly suspecting PE, you have to repeat CTPA again after 3 days. Thank you all for attending today. I wish you the best, and kindly, if you can fill the feedback, I'll be grateful for you. Thank you all. Bye-bye.